Welcome to this video on Medical Impairment Assessment, Practical Applications, which is PARTY, Ergonomic and Occupational Psychology. We will cover medical impairment assessment, focusing on injury and disease assessment, including the upper and lower limbs, as well as the cardiovascular, respiratory, and hematological systems. Historically, medical impairment assessment served as social justice through monetary compensation. The WHO developed the International Classification of Functioning, Disability and Health, or ICF, which looks at body functions and structures, activity, and participation. Impairment ratings are vital for ensuring appropriate compensation, safe return to work, and job matching to prevent future injury. This diagram illustrates the ICF model, showing the interaction between a health condition, body functions and structures, activity, and participation, with environmental and personal factors also influencing the process. The purpose of permanent impairment assessments is to use diagnostic criteria and evaluation processes that incorporate scientific evidence and medical opinion. Determining a claim requires an assessment from a medical specialist. This assessment informs the claims manager, who ultimately determines the outcome, as seen in both the USA and Malaysia's professional qualifications for assessors. The SOCSO Disability Management Guideline details the content and structure for disability management, covering history, process, eligibility, return to work, benefits, specialty, and glossary. For the upper limb, this visual details various prosthetics, including cosmetic and functional types, along with their specification, suspension systems, and the typical timeline for fitting and training. This slide discusses challenges and solutions for both upper and lower limb prosthetics, covering issues like swelling, weight, functionality, and cosmetic considerations, along with different types of lower limb prosthetics and suspension systems. The process for lower limb prosthetics involves healing, fitting, and training over several months. Various suspension systems are shown, along with factors for good prosthetic fitting and an overview of the rehabilitation team's intervention. Welcome to this video on medical impairment assessment, practical applications. We will focus on the cardiovascular system and how medical impairment is assessed within this system. Impairment evaluation uses a structured framework to assess permanent cardiovascular impairment and its impact on daily living activities. This video will cover the core principles, methodology, and classification tools used by medical assessors and clinicians for these evaluations. Cardiovascular impairment evaluation requires a standardized and evidence-based approach. The methodology is built upon three core principles: the OWN Functional Impairment Standard Format, Burden of Treatment, and the New York Heart Association Functional Classification. Principle 1, the OWN Functional Impairment Standard Format, focuses on objectively quantifying functional capacity through exercise testing, measured in metabolic equivalents, or METs. Methods include treadmill testing, bicycle ergometry, and myocardial imaging and perfusion assessment. Different types of cardiac stress tests are used in the assessment, such as the exercise stress test, stress echocardiogram, nuclear stress test, pharmacologic stress test, cardiopulmonary exercise test, and stress MRI. Principle 2 is the burden of treatment concept, or BOTC. This model uses the type and number of medications as a surrogate for disease severity. More medication equals greater impairment burden. The clinical significance of BOTC is that treatment intensity reflects the underlying disease burden. Principle 3 is the NYHA Functional Classification, the mainstay reference for grading cardiovascular impairment severity. It is a clinically validated system correlating symptoms with functional limitation, ranging from Class 1, no limitation, to Class 4, inability to carry on any physical activity without discomfort. Impairment grading is performed when the claimant reaches maximum medical improvement, or MMI. The specific disorder determines which criteria are applied. Evaluated cardiovascular conditions include valvular heart disease, coronary artery disease, cardiomyopathies, pericardial heart disease, and others. A thorough physical examination is essential, interpreting clinical findings alongside objective data. Assessment includes cardiac function based on tables 4.1 to 4.3, and end organ damage, which influences the final impairment rating, using tables 4.4 to 4.14. Determining the impairment grade follows a structured, three-step methodology. Step 1 is determining the key factor, which anchors the overall impairment class. Step 2 identifies non-key factors to refine the grade. Finally, Step 3 involves summating all factors for the final impairment grade. The impairment determination methodology relies on various reference tables. Cardiac function tables include NYHA classification and exercise testing results. Disorder-specific tables cover conditions like valvular heart disease, cardiomyopathy, and hypertensive cardiovascular disease. Using the correct table is crucial for a valid assessment. Key takeaways include assessing only at MMI, applying NYHA and BOTC together, ensuring objective testing is essential, and following the three-step summation process for accurate impairment rating. This video will focus on the practical applications of assessing permanent impairment related to the pulmonary system. The pulmonary system impairment assessment uses a structured clinical framework. It incorporates functional assessment, burden of treatment, and evidence-based guidelines from the American Thoracic Society (ATS) and the European Respiratory Society (ERS). The core objective is to evaluate permanent pulmonary impairment and its effect on an individual's ability to perform activities of daily living, including self-care, mobility, and work-related tasks. The assessment framework includes functional assessment, burden of treatment, and adherence to ATS-ERS guidelines. A systematic history is foundational for pulmonary impairment assessment. Key domains include respiratory symptoms, environmental and occupational exposures, and lifestyle risk factors. Thorough tobacco history, including cumulative pack years exposure, is also essential. A detailed occupational history is critical for identifying causally linked pulmonary conditions. This includes a chronological work history, a chemical exposure assessment focusing on frequency, duration, and intensity, and reviewing safety data sheets, SDS, for toxicological profiles and exposure limits. Clinical evaluation includes a physical examination of the respiratory system. This involves a comprehensive assessment, including observation, palpation, percussion, and auscultation, to identify signs of pulmonary impairment and other systemic effects. Physical examination findings must be correlated with functional test results. Chest imaging, such as plain radiography and CT, is used to identify parenchymal and dust-related abnormalities. Musculoskeletal conditions like kyphoscoliosis must be considered as they independently restrict pulmonary function. Objective physiological testing forms the cornerstone of pulmonary impairment rating and must comply with ATS-ERS technical standards. This testing includes spirometry, DLCO measurement, and cardiopulmonary exercise testing for objective functional capacity measurement. Peak flow measurement is a simple and important test. It involves a systematic procedure: purchasing a peak flow meter, placing the marker at 0, standing up, inhaling deeply, placing the mouthpiece, blowing out hard and fast, writing down the number, and repeating the process twice. Static lung volume measurements provide essential context for interpreting spirometry results. Key parameters, including total lung capacity, TLC, residual volume, RV, and functional residual capacity, FRC, help distinguish true restriction from air trapping. Impairment assessment is only conducted once maximum medical improvement, MMI, is reached. The methodology varies by underlying diagnosis, covering conditions like asthma, hypersensitivity, pneumonitis, pneumoconiosis, lung cancer, and sleep disorders. The AMA Guides methodology uses a structured, multi-step grid approach. Impairment integrates clinical findings, functional data, and treatment burden, starting with assessing pulmonary function, determining the key factor, identifying end organ damage, determining non-key factors, and combining for the final impairment class. In summary, key takeaways include deferring ratings until maximum medical improvement is reached, integrating multiple data sources for a comprehensive assessment, applying strict ATS-ERS standards for testing, and systematically using the impairment grid for a defensible rating. This video will introduce the hematopoietic system and the framework for assessing impairment arising from its disorders. The diagram illustrates the formation of blood cellular components from hematopoietic stem cells. The hematopoietic system impairment assessment uses a structured framework for classification and grading. It covers disorders of the bone marrow, lymphoid tissue, and hematological function. The system includes the bone marrow, lymph nodes, and spleen, regulating blood cells and immune mediators. This includes growth factors like GCSF and inflammatory mediators such as TNF and interleukins. Dysregulation affects activities of daily living. Hematopoietic impairment assessment requires a rigorous methodology based on 3 pillars: interpreting signs and symptoms, detailed clinical history, and functional testing. The ECOG Performance Status Scale is recommended for oncological conditions. Burden of treatment and compliance, or BOTC, is crucial to impairment assessment. Pharmacological interventions impose a physiological and functional burden on the patient. BOTC ensures treatment dependency is weighted correctly in the impairment classification. Impairment grading covers the full spectrum of hematopoietic disorders, each with distinct diagnostic criteria. Categories include anemia, myeloproliferative disorders, WBC diseases, hemorrhagic and platelet disorders, thrombotic disorders, and malignancies. All impairment grades must be determined at maximum medical improvement, or MMI, when the condition has stabilized. Assessment before MMI risks inaccurately rating the true degree of permanent impairment. The grading methodology is a structured three-factor assessment. It integrates physical examination, hematological function, end organ damage, and diagnostic findings. Multiple diagnoses are assessed independently and then combined. A structured physical exam and functional evaluation are the core of impairment grading. Findings must correlate with laboratory data and clinical history. End organ damage must be independently documented and factored into the combined impairment calculation. Disorder-specific impairment tables provide the quantitative framework for standardized ratings. Each table corresponds to a disorder category and defines threshold criteria for each impairment class. In summary, key principles include assessing at MMI when the condition is stable, using disorder-specific tables for grading, accounting for the burden of treatment, and combining multiple diagnoses when necessary. Disability assessment and impairment rating complete the loop in occupational medicine. Becoming a competent person, like a CIME or CMIA, requires proper training and mastery of specific knowledge, skills, and practices. Thank you for watching this video. We would like to acknowledge AP Dr. Anita Abdul Rahman,